All right. Good evening, everyone. I'm Dr. Camille Vaughn. I'm the Division Director for Geriatrics and Gerontology at Emory, and I am pleased to welcome you to the 11th Annual Betty Rose Connell Memorial Lecture, which, in a true spirit of collaboration, representative of Dr. Connell's spirit and partnership throughout her career, is co-sponsored by the Emory Division of Geriatrics and Gerontology, the Atlanta VA Rehabilitation Research and Development Center for Visual and Neurocognitive Rehabilitation, and with additional support from the Birmingham Atlanta VA Geriatric Research, Education, and Clinical Center, and the Emory Woodruff Health Sciences Center for Health and Aging. And if you would like to partner with us to support this lecture series, there'll be an opportunity to learn more about that as we conclude tonight's event. I'd like to thank several individuals who've made tonight happen. We appreciate Dr. Madeline Hackney's leadership as chair of the Betty Rose Connell Memorial Lecture Committee, as well as committee members, Dr. Molly Perkins, Dr. Katharina Echt, Ms. Nakia Mitchell, Mr. Jason Friege, Dr. Lee Partington, and Ms. Marisa Warner. And we're also grateful for the continued support and partnership with the Atlanta VA CVNR, including Executive Director Dr. A.M. Barrett and Administrator Lisa Callis. This year, I'd also like to give a special shout out to Dr. Patricia Griffiths, who was the inaugural chair of the Betty Rose Connell Memorial Lecture Committee, as well as a mentee and colleague of Dr. Connell's. Dr. Griffiths retired in 2020 from the Atlanta VA after 22 years as an investigator, and she retired from Emory in this past April of 2021. And we're delighted that Dr. Griffiths will remain engaged as an emeritus faculty member, and we appreciate her contributions to research focused on optimizing supports and resources for caregivers. And hopefully at some point we'll get to do something in person to celebrate Dr. Griffiths, but didn't want to leave tonight without saying a few words. As we begin tonight's event, I'd like to share just a few thoughts about Dr. Connell and her impact at Emory. She was a fierce advocate for older adults, particularly those living in nursing homes and persons with dementia. She promoted the concept that abilities-oriented care, which involves promoting staff and resident interactions that engage resident self-care, was essential to improve and maintain quality of life for persons living in long-term care settings. And I recall fondly as a summer medical student, couple decades ago now, learning about geriatrics research, observing Dr. Connell in a friendly but heated exchange with our then division director about next steps in a research project. I don't remember exactly what the debate was about, but I admired her passion and her focus, particularly on behalf of a population and setting of care that sometimes is ignored by society. And tonight, as we remember Dr. Connell's legacy at Emory and at the Atlanta VA, we're privileged to hear from a long-term advocate and thought leader for best care practices in nursing homes, as we raise also awareness of the important implications of the COVID-19 pandemic that have really highlighted again the need to optimize care for this most vulnerable population. And so I'll now turn it over to Dr. Hackney to introduce our invited speaker, and I look forward to an engaging evening together.
Thank you, Dr. Vaughn, for your words about the importance and the reach of the Betty Rose Connell Lecture. Hello, everyone. We are thrilled you have joined us. I'm Madeline Hackney, the chair of the 11th Annual Betty Rose Connell Lecture Series. At both the VA and Emory, Dr. Betty Rose Connell was continuously investigating how one could improve the lived environment in nursing homes and our personal homes. She explored and researched ways to facilitate our caring for others at home and environmental strategies to support successful aging in place. As we work our way through the second autumn season of the COVID-19 pandemic, I wonder what Dr. Connell would have suggested. I'm sure she would greatly approve of our use of telecommunication to continue her legacy through this lecture series. Our keynote speaker, Dr. Vincent Moore, whom I will introduce momentarily, will take questions after his presentation, which I will moderate. Please use the Q&A feature to submit your questions. The Q&A icon is located at the bottom of your screen. We will answer as many questions as possible and will take them in the order they are received. Following Dr. Moore's lecture and Q&A session, importantly, we will be sending out a SurveyMonkey evaluation to your email addresses immediately after the event. Please fill out these surveys so we can continue to enhance this lecture series. We want to hear from you. Now, I would like to tell you about our keynote speaker, Dr. Vincent Moore. Vincent Moore, PhD, is the Florence Purse Grant Professor of Community Health in the Brown University School of Public Health, and also a research health scientist in the Health Services Research Service at the Providence Veterans Affairs Medical Center. Dr. Moore has served as principal investigator of over 40 NIH-funded grants focusing on health services and the outcomes that frail and chronically ill persons experience. His research evaluates the impact of programs and policies in aging and long-term care, including Medicare funding of hospice, changes in Medicare nursing home payment, and the introduction of quality measures. He was an author of the congressionally mandated minimum data set for nursing home resident assessment and the architect of an integrated Medicare claims and clinical assessment database used for policy analysis, pharmacoepidemiology, and population outcome measurement. This data resource is at the heart of the NIA-funded program Project Grant, Changing Long-Term Care in America, now in its third renewal cycle, which examines the impact of Medicaid and Medicare policies on long-term care providers and the patients they serve. This integrated data structure is also at the core of a series of large, pragmatic cluster randomized trials of novel nursing home-based interventions. Building upon this work, most recently, Dr. Moore and colleagues were awarded a large grant from the NIA to solicit, fund, and support multi-site pilot non-pharmacologic intervention projects embedded in healthcare systems designed to improve the lives of persons living with dementia and their caregivers. This program will test whether interventions found to be effective when implemented by researchers are still effective when embedded in a functioning healthcare system. Dr. Moore has been an active BAHS R&D investigator for the past decade and helped establish the Providence BAMC Center of Innovation, or a COIN, where he now directs independent investigator-initiated research projects focused on the VA Geriatrics and Extended Care Service. Please welcome Dr. Moore.
Thank you very much. I'm going to share my screen now and see if we can move forward with this. Can you all see that? I hope that works. So thank you very much for that lovely introduction. I appreciate it. So I'll be talking to you today about COVID-19 and US nursing homes and what the implications are for the future. I got funding from a large program Project Grant, also a number of different supplements from the from this large impact grant looking at COVID-19 and its effect on people with dementia in the nursing home setting. What I'd like to do is to summarize the initial framing of COVID in the US nursing homes and how that emerged. Tell a little story about how we got involved with that activity. Then look at the major determinants of COVID outbreak and mortality. Then we've been looking at this in a variety of different ways using these data from other sources and looking at testing and vaccination rates. And I'll briefly talk to you about the results of a trial which is we finished in record time to increase vaccine uptake amongst residents as well as staff, and then present the first results on vaccine effectiveness in the US nursing homes. And then finally, to bring this together, what are the implications for policy on US nursing homes as it moves forward? So it's a lot of different moving parts, and I'll try to keep you entertained in the process without going too far afield with stories. So a little background. We will all remember the first outbreak at a Kirkland, Washington State facility, which many people died, and there was no testing. Staff didn't have protective equipment, and it was just the first crash identification that there was going to be hell to pay, that nursing homes were going to be hotspots simply because they were full of the most vulnerable populations. They had lots of population density, and they had so many quality problems that people could recognize in the past. And so people began to think about these nursing homes as the worst of the worst. And it was a crisis for nursing homes around the country. But that crisis didn't actually come out till later because most of us were so focused on hospitals And so that nursing homes were in some sense really an afterthought to hospitals, where hospitals in the ICUs in New York and other New England, northeastern states were really the focal point, the epicenter of where people were dying and where ICUs were being used to try to support all these people who were sicker than most anybody else had ever seen from a pandemic, at least in recent memory. So in the absence of early federal guidance, states began to set their own policies around nursing home care. So in New York State, nursing homes were told you had to accept patients being discharged, often still with COVID present, from hospitals, because they needed to empty the beds in the hospitals because they were full of COVID patients. And if this patient was surviving, had gotten over the worst of it, then you could actually send them off to a nursing home. And so that notion of mixing patients with active COVID with patients who are in nursing homes who may or may not have had it already, and how those things were happening, all of that was this cacophony of crazy policies, particularly as states were grappling and coping with a crisis that was in Massachusetts, in Vermont, and in Pennsylvania and New Jersey, like particularly in New Jersey. And so emerged in like April, May, June, this sort of alternative narrative. One was blame the nursing home, that COVID was just an exacerbation of really what were poorly provided care, facilities that just couldn't actually get it together to manage the care of their very frail populations. And that notion was that poor nursing homes had more outbreaks, more deaths, higher risk, and if only they were better, things would be better. There was also an environment where people weren't investing in nursing home managers and staff, and this poor preparedness and poor availability of resources and willingness to be for profit, and therefore to extract rents from government programs and to take the money and run. That was all part of the image of poor performing nursing homes, which were literally bad places for people to be. An alternative interpretation of what was going on was that this was essentially an inadequate public health response. And my team and my colleagues and I over time have actually pushed this particular interpretation, where outbreaks and deaths occur in counties where the virus is prevalent. And that staff who are nursing home staff, because they're poorly paid, live in poor areas, in poor communities, and in highly dense housing arrangements, bring the virus into the buildings. And there was inadequate testing equipment, inadequate testing capacity, poor tests, and inadequate protective equipment. And that, protective equipment, even when it was available, really couldn't guarantee protection. And as during that time, I can't tell you how many conversations I had with people from the New York Times, Washington Post, and whatever. And we would have conversations, and I would say, you have to understand, this is amazingly and incredibly intimate work with patients. So imagine you have a 150 or 170 pound patient who is bedbound, and you need to get that patient into a wheelchair so that you can move that patient for meals, or you want to bring the meals to the patient. You want to make sure that that patient doesn't acquire pressure ulcers so that you're turning him, and otherwise that, by most nursing home requirements, requires a 2-person lift. In order to do that, one staff member is on one side of the person, another staff member is on the other side of the person, and their faces are literally inches from one another, and they're going to lift that patient, exerting enormous exertions, stress, and breathing heavily in the process. if one of those staff members came from a household where one of the people who works in another nursing home, or one of those people works in a supermarket or in a transit authority, and they've acquired COVID and no one in the household knows it yet, and that staff member has been exposed and has gotten the virus, then they're going to pass it on to their other staff member, and they're going to pass it on because they're also inches from the patient to the patient. And yet that two-person lift is required and is necessary. It's just amazing. I would talk to the reporters, and the reporters never thought in their minds what it was like to work in a nursing home, the nature of the work, and how the nature of the work might then contribute to the passing on and the transmission of the disease or the transmission of the virus. And I said, protective equipment can help when it's worn properly and it's done properly, but often it wasn't in the early days even available. And even when it's there perfectly worn, it's not a guarantee. It reduces the risk of transition. It is not 100% guarantee, particularly in this intimate kind of work. So by and large, throughout much of the spring and into the summer, the sort of the poor nursing home story was the one that actually had the greatest traction. And here's a piece from the New York Times. They are death pits. And I can't tell you how often I call back after this, because I spent a lot of time talking with people for this report. And these are the death pits, 7,000 lives, more people lost in nursing homes than any other setting as a proportion, huge, like even right now, over 30% of all the deaths occurred amongst people in nursing homes, which is just huge, but it's the nature of the environment and the nature of the transmission process. So our work looked at this. We looked at variation in prevalence in U.S. skilled nursing facilities as a paper in the Journal of the American Geriatric Society. And here we see that the most important factor, whether it's in the Genesis facilities or other skilled nursing facilities from multiple states across the country, the most important factor was the county cases per 100,000 as a proportion. So if you're looking at a facility that had no cases versus a facility that had at least one case, 4 times as high if you're in a county where it's prevalent, strongly suggesting that this is a county-borne or a public health phenomenon, and not is it just the nursing home, because the 5-star ratings, virtually no difference in those quality measures of any sort. Because the transmission is all about the staff, and even the staff were mostly asymptomatic. When the proper epidemiological work has been done from even the spring of 2020, and particularly as we've gotten more and more data, a very high proportion of all positive cases are completely asymptomatic or largely asymptomatic, that they don't know. And once infected, most patients were also asymptomatic. So imagine you're in a nursing home, and we work very closely with a number of nursing home companies, and particularly with Genesis. And they initially, particularly because they were in the Northeast, they struggled with trying to do what's called cohorting, trying to get patients from who were positive to be with other patients who were positive, to have patients who are negative, all with patients who are negative at one end of the nursing home, the other end of the nursing home, and then ultimately try to isolate the staff so that there's no movement. But if staff go home every night is a new possibility of exposure, a new possibility of becoming positive. So you don't actually know the rate of asymptomatic positivity until there's sweep testing. And many nursing homes did not do sweep testing until well into the summer or the fall, when CMS began to give them antigen tests on a regular basis. So Genesis was very much focused on doing sweep testing to try to get a handle on this stuff. And we worked very hard with them because we were downloading their data every single night. Shortly after the first cases at Kirkland, I reached out to my colleagues at Genesis. We used their data for some of my cluster randomized trials in the past. Said, let's do our data downloads every night. We'll work together. We promised to try to use the data to help solve your operational problems. And so that began a really long-lasting relationship of great trust with them as they worked together to try to solve problems that they were struggling with. And we tried to help in that process. So here's from another paper that we had in JAMA Internal Medicine, where we looked at the asymptomatic or the pre-symptomatic or the symptomatic cases. And about 40% of the cases, or when there was a point prevalence survey of cases, were asymptomatic. Another 19% were what we call pre-symptomatic. They were symptomatic they were asymptomatic at the time of testing, and only later did they become positive. And then about 40%, or almost just under 40%, were from the positive side. So imagine you have no basis. You only have the test results, and for months and months there were no tests. People didn't have tests, or the tests you had came from the health department, and they were the PCR tests, and you had to wait 5 days or 7 days before you got the results, which are pretty useless by that time. But people continue to push those kinds of tests in many states. Would have been the same. So then we began to look at the predictors of particularly mortality. We also looked at the predictors of becoming positive. The predictors of becoming positive were virtually all environmental. That is, was there another case in your building, in your wing? Was there, what's the rate of the of transmission or infection in the local county? But once you got the disease, you would actually then say, what are the predictors of 30-day mortality? And as you can see here, age is huge as a proportion. So if you're under 65, much younger. If your function, because this is ADL from the EMR of the facilities, the highest ADL had the highest rate of mortality, and even more so was cognitive functioning. And once we put all these into a multivariate model, cognitive functioning and dementia, as well as a very advanced age, had very strong ongoing effects. This was another paper in JAMA Internal Medicine. What was very interesting is over time, here is 315, the first cases in Genesis facilities, out to the end of November. And we saw that here as well, we had enormous differences in the rate of mortality, both as a function of whether you're symptomatic or asymptomatic, as well as the what your cognitive functioning, as well as your ADL functioning. So those people who had the worst cognition and the worst ADL, this red line here, they had the highest rate of mortality early on, but it declined almost parallel. And so they continued to be higher than the others. This is mortality amongst those people who'd had an infection. So all of a sudden, it's the fall or the late fall of 2020, and vaccines became real. We were very much involved talking to people from the, what's the name of the group that the real time or the rapid fire, I can't remember the name off the top of my head now, but they were, we were talking with them, and it became clear that in time that the government was going to get the healthcare workers, and then immediately after the healthcare workers were being vaccinated, the nursing home residents were going to be vaccinated, and nursing home staff would be vaccinated. So the CDC reached out to us and talked to our team about doing real-time adverse event monitoring. It's had never been done in nursing homes before. So CDC actually uses the Kaiser Permanente system in California for some real-time care monitoring of vaccination or vaccine adverse events. and as part of their vaccine monitoring, but had never done it in nursing homes before. And we had real-time, every night data. We knew exactly who was going to be vaccinated. We knew exactly the array of diagnoses that they would get. And so we were able to compare centers, nursing homes that had been vaccinated earlier, like from December 18th and 19th, and those that were vaccinated later in the cycle in mid-January. And so we could look at the adverse events of the people in the two groups of nursing homes, where it's not the patients who are being vaccinated early or late, it's the buildings that were being targeted as part of the distribution, which really had nothing to do with what areas were targeted first, because these were done by whether CVS or Walgreens was doing this with people. Again, it's particularly important because shortly in the January or January 2nd or 3rd or something like that, Norway and the UK press began reporting that there were deaths of old people right after they were vaccinated. And so the importance of having a control group is really critical when there's a high background mortality rate, which of course there is in the nursing home context. And if you look down here, here's the mortality rate of 91 people died in the vaccinated group in the early facilities. And then the 284 facilities were vaccinated late. They were also, that was in the people had not yet been vaccinated. This is the second dose in these 85 facilities. And here it was virtually the same, 657, 567 relative to the unvaccinated group, which was higher. And so we looked for a variety of different other diagnoses that would have occurred in the 7 days afterwards. And basically there was no difference in any of these factors. A paper is coming out on this where we looked over a longer period of time just now. The first author is Barbara Bardenheier. I think it may be out already. So the next, where do we go here? The next one. So we're now going to talk about staff vaccine hesitancy in staff, as well as and as a gear up to this trial I'll be talking about. So we basically did a survey of staff from a single state. We found that 45% would take the vaccine quickly, 44% thought they might take it in the future, 11% would refuse, and that younger women, younger people, women and Black staff were more likely to be hesitant about this. Now, since the staff in the Sniff, in the nursing home workforce is mostly women, a high proportion are African American or Hispanic, and most are poor, there's the people who are most hesitant seem to be nursing home staff. So we put together a framework, and this is with the CDC framework, was what people think and feel about the confidence of vaccines, whether they think there's safety, whether they're safe for themselves or for others, and whether they're, what the vaccination norms are in those particular places. Are there, who thinks they're important in those places? All of those things will affect the motivation to get vaccinated. And then, of course, there's practical issues. You need to know where the vaccine is going to be available, whether or not there's been previous uptake of the vaccination, for instance, influenza vaccination, and whether there's ease of access and it's available. And then, of course, that's whether somebody receives the vaccine is a critical factor in that whole process. So we began to think about different strategies, and this is literally as we put together this intervention program in a 3 or 4 week period, and we began to think about local champions. And during our surveys, one of the people said that our qualitative response was, one of our local leaders was on the news because she got vaccinated. She's Black, but she's Black and young. Somebody says, I'm Black and old. I'm an older person. I want to see someone like me who says they got it and it was okay and fine. A positive social message was also important. So somebody said, I'm a medication aide at a nursing home. If it was up to me, I wouldn't get vaccinated. but knowing I want to keep my residents safe, I want to keep my own kids safe, and essentially I don't want the residents to go back to whatever, to have whatever life is normal, because these people working in the nursing homes see what a devastating effect that isolation and the pandemic has, or the secondary effects of the pandemic has had on these patients, and particularly at the end of their lives. And it was just sad. I mean, the stories we heard about people who they loved, their residents that they cared for, and how life was miserable for them and very difficult. So we did this survey of Sniff workers' attitudes, and we did, again, mostly white respondents. We asked things about how confident they were, and whether they had a trust in the leadership and the managers, et cetera. One of the things we found was really interesting was that the association between the organizational support and the confidence in the vaccine was very strong, but even stronger, it was very strong for both white and Black nursing staff, even though nursing staff had a lower sort of confidence in the vaccine. If they were in an environment where they trusted and had confidence in their leadership, that also was a strong positive effect. So with all this information, I'm going to sort of skip this case control study and spend a little more time talking about the trial we did. So we did an embedded pragmatic trial to increase vaccine uptake amongst both nursing staff and residents. So we had planned to do a study of increasing testing and making testing increasingly available in the nursing home setting. And as part of doing that, we realized that by the time basically September, October of 2020, CMS had already given the Abbott vaccine machine to virtually every nursing home in the country. And so staff and testing was not a problem for most nursing homes. Actually getting ready and improving vaccination uptake was the real challenge. So we drew on an established network of nursing homes from that we've been working with in the past, as well as those who are sharing data with us, because we're getting downloaded data from these companies once a month, in addition to the once every night from Genesis. And so we developed an intervention in just a week based on both the CDC model as well as best practices and some of the evidence noted from both the case control study as proposed, as well as the evidence from the surveys that we had. So the intervention talked about electronic messaging and education. It talked about defining and identifying and working with opinion leaders in each participating nursing home to try to get them to train them to understand how their colleagues might be nervous about this and how to talk to them about them, not beating them up, not pushing them too hard, but sort of answering their question and saying there's no such thing as a dumb question, and that keep thinking about this in terms of the protectiveness of this, and that once you get to an empirical question like does it work or does it not work, there's lots of evidence to support that, and the evidence is there and it's available, but really we have to actually deal with people's concerns where they are. So we want to have positive reinforcement, let's say in the form of t-shirts or other kinds of buttons and things like that, that could be distributed and sort of become part of the culture. We also, for patients, had consenting specialists, because some patients, particularly those where family members had concerns, they might have concerns about this, and they were making the decisions on behalf of their family members, on behalf of the residents in the building. And as part of this, because we were very concerned that the symptoms, the initial first day symptoms of having a COVID sort of reaction to the test, to the vaccine, looks a little bit like COVID itself. We actually made available enhanced testing and funds for enhanced testing for the nursing home so that they could increase the number of bits that they would have for for the antigen tests that they would have for people who came in feeling feverish or not too terribly well or uncomfortable after their shot. And so, because otherwise, if they were symptomatic and there wasn't a test to go along with it, they could be quarantined for 14 days and the facility would lose a very valuable worker because of an adverse reaction or the standard reaction to the vaccine. So we looked at 4 Sniff chains with geographic and racial diversity. We looked at long stay residents who've been in the facility for 100 days or more and who were in the building at the time of that first vaccine clinic, basically that occurred between December 18th and let's say January, toward the end of January. And then the second one occurred largely in February and the beginning of March. For staff, we looked at regular staff when we excluded healthcare professionals that were unlikely to work in the facility full-time, like physicians, nurse practitioners, or dentists. Here's what the study design was. We looked at all eligible facilities in 44 SNFs. 21 of them were dropped because some of these buildings were actually being sold or otherwise that were unstable in that perspective. We randomly assigned 133 of these buildings after stratifying them in terms of the proportion of the residents who were minority into these groups of under 25, 25, and over 40. We wanted to make sure we had really good representation of both residents and staff. And then we did random assignment at the building level. Our primary outcome was a count of the long stay residents with any dose of COVID-19 vaccine by March, the end of March of 2021. And we derived that information directly from the EMR. As I mentioned, those EMR data were downloaded to us every month from all of these companies. The other primary diagnosis outcome was the count of the staff with any dose of COVID-19 who had had the vaccine. The vaccine sources came from vaccine logs. That's the count from each building. We used the PBJ, which is the payroll-based journal from CMS. We actually had this at the individual level from one of our colleagues who got these detailed data under a FOIA exemption, and which led us to a unique count of the staff in the denominator for that rate. And then we looked at secondary outcomes stratified by race and job type and implementation, the kind of implementation measures that we were using. So here are the resident characteristics. We had a very large population of African-American residents. Almost half of these people had had a COVID diagnosis before in the past. These are long stay residents, long since gone through. Most of them had, as I noted, had asymptomatic. And these are the kinds of comorbidities that they had. So it's a sick group of long-term care residents. This is the kind of buildings they lived in. There were about 114 beds, 110 beds on average. About 9% of them had an Alzheimer's special care unit. About 2/3 or 3/4 were for-profit because we were selecting by company. And the 5-star rating, we had all different kinds of buildings. The number of staff was about 131 staff. And the number of nurses per aides, the number of nurses or aides was about 93 or 92 in the building. And so those were the numbers in our study. While there was a lower rate there was no difference whatsoever in the marginal probability of vaccination between the experimentalists and controls, somewhat more for the effect estimate was somewhat higher for the staff, but still no difference in the confidence intervals. This was a study that we first got permission to do in like the second week of December, and the study was all done, completely engaged with the data collected and in-house by the end of April. So it was an amazing relatively quickly done study. And so it's not, we wished it would have been more effective. We tried desperately to be able to do something more, but the timeline was really was quite significant. So here's where we originally got our funding from for the overall study. We were able to get the pivot NIA approval for that by December 13th. The IRB approval and our first data safety monitoring board was right after Christmas. And then we had town hall meetings with et cetera. So this was during the intervention period. And so we were so this was during the intervention phase. Now, mind you, this is the count of the number of people who had been vaccinated, not the number of people who had been had a COVID diagnosis who were nursing home residents during this period. So at the peak, and then as soon as the as soon as the vaccines began being delivered, which was right about here, which was basically December 18th was the first one, the rate of new infections began dropping quite quickly. So what were the lessons? Increasing vaccine uptake in nursing homes, it requires consistent, accurate reports of vaccine uptakes was very challenging. Acquiring that stuff was challenging. It takes time to improve trust, establish frontline champions. It's inexpensive strategies that are easily implemented can be effective, like having, gifts that people love, the stuff, the little swag we gave them. And it really got people up. We had lots of images and views on Twitter and so on and so forth, but it's clearly not enough. Organizational cultures, I think I showed you, is important. Trust in leadership is important. And even as we see now, people are willing to leave their jobs to get fired, let go, and even in settings like Massachusetts and New York, where you can't get a job without being in healthcare, without being vaccinated, some people are leaving the entire field. So it's a much more complicated thing. It's been politicized and it's difficult, but it is possible to move that needle. And mandates, we're now examining what the extent to which mandates actually do make a difference. You lose people, but does it increase the rate of uptake? So vaccination. Vaccine has been extraordinarily effective. The number of new nursing home cases began to decline even before the vaccines began. So what we had to do was compare residents in early versus later vaccinated facilities. We looked at this cumulatively over 5 weeks period. The reduction in new infections was around 12%. And then we also looked at the composite of 30-day mortality or hospitalization. And 5 to 8 weeks post-vaccine clinic relative to the early vaccine, relative to the early versus late vaccine facilities, they had 4% fewer deaths or hospitalizations. And so this is really important that the vaccine worked in this very sick population. And as I showed you earlier, the adverse effects were quite minimal in this population. And here we could see the incident SARS infection amongst nursing home residents receiving first and second vaccines. And here we see that after, at 15 to 28 days, we're looking at 1%, 0.04% after the second vaccination. And most of those people were asymptomatic. That is, they got the vaccine, most of them repelled any subsequent infection, and most of those who were positive, because anytime there was a positive case in those buildings, there was a sweep testing for everybody in the building. Most of those were asymptomatic. And the rates dropped even further for those who had 2 doses. So this is an extraordinarily effective vaccine. Here's what we show is that the most of the residents who received doses 1 and 2 is about 10,000. Incident cases, that is their new cases, 14 days after the dose was only 140, and of those, 116, the vast majority, were asymptomatic, and the percent of infections that were asymptomatic was about 82%. So we're now looking at time to breakthrough infection. As you know, we're now looking at boosters. Nursing homes are beginning to administer boosters across the country now. And these are data from, again, Genesis. And here we see the time to breakthrough infection. So here we see that there are some breakthrough infections that occurred in that first 14 days, but after that, it plateaus to literally 1, 2, 3 maximum. And then by the time you're at 154, 160, 180 days, you begin to get a little spike. We're now looking at this with more recent updated information, and there continues to be a predominance of asymptomatic cases in these cases, and very few patients, and we're now looking at that, are being hospitalized or dying in that group. So, what are the consequences? What has this disaster meant for U.S. nursing homes? So let's look at this sort of from the broad institutional perspective. But even before COVID, the occupancy and length of stay in nursing home was declining for a lot of different reasons. Medicare Advantage was using them, but they would authorize fewer and fewer days. Accountable care organizations all of a sudden were accountable for those skilled nursing facility days, and they began to make huge inroads to the extent that ACOs have saved money. They've saved money by basically taking it out of the nursing homes, so that fewer days in the of Sniff stay under the ACO, and bundles also did the same thing. All of those serve to reduce length of stay well before we had a pandemic. Like hospitals, nursing homes lost revenue, fewer post-acute admissions, and all of that stuff occurred during when COVID began. So there were, the occupancy rate and the number of empty beds increased dramatically, just like in hospitals after the COVID crisis passed. Costs increased, supplies, testing, treatment, staffing costs. Already low Medicaid rates may be frozen in the future once the feds stop passing money directly through Medicare to keep these nursing homes from going belly up. There's a rising risk of bankruptcies. There's I don't know if you've noticed it down in Georgia, but we're noticing a number of divestitures that are occurring as nursing home companies are just not able to sustain and don't see the ability to sustain when the Medicare money goes away, facilities that are in poorer areas. And so they're divesting them, selling them off to other companies, which are going to try to make a living off of skimping. So where do we go from here? So the nursing home industry arose, and I've been doing this for a long time. So I've been doing this literally since the 70s. In the late 60s and 70s with Medicaid and the need to care for the last generation that was born in the 1800s. And so there's been this growth of people when there was a large population of residents of the elderly population, when the elderly population was growing because of the numbers of people born and the extended life expectancy. During the interval between the 1970s and presently, expectations of the population have changed, and quality standards and policies have changed. And it's a very different business, and the nature of a nursing home patient has changed radically, much more likely to be very sick, dying, or post-acute care. I can't tell you how many nursing home patients I've seen who've been discharged directly from the ICU to a cardiac rehab setting in the nursing home, which is very different than it was in the old days. Nursing homes, by and large, most of them provide both social and medical care. There are some nursing homes that concentrate just on post-acute care, and they're run more like hospitals than long-stay nursing homes. It may be in the future, we have to think about separating post-acute care from residential long-term care. Because post-acute care, there are always going to be people who need some kind of post-acute care because their families aren't home, they live alone, they can't go directly from the hip replacement or the hip fracture to directly to home where they live on a third floor walk-up. They're going to need someplace in between. That's different care than long-term residential care. May not be always so much different, but it is different in many respects. And so it's critical to continue to monitor these providers since they serve such a vulnerable population, whether it's the post-acute care or the residential long-term care. But that's going to cost. So right now, the people who are 80 to 85 and the 80 to 90-year-old, that is the population of people who were born in the 1930s. That's the midst of the Depression. The number of older people born then was at a nadir relative to the people afterwards in the baby boomers. But as the baby boomers, that's me and people like me, begin to hit 80, which is still about 10 years from now, there's going to be a big demand for some form of residential care, some kind of solution. So those beds are not going away. The question is what are they going to look like under those circumstances? And how do we learn the lessons of a pandemic to keep a place still home-like, but also to protect those vulnerable patients in there? And that's a real challenge as we go forward. So thank you very much for your time. I hope I didn't talk too long, and I'm happy to take any questions you have. And I think I should probably stop sharing now. Is that right?
That is, you can,
Right.
yes. Hold on a second. Dr. Moore, thank you so much for a great presentation. We've learned so much. Thank you so much. I believe we should have a few questions. I'm just going to wait for a few folks to type them into the Q&A. I found that part that you were just talking about where we go from here to be especially interesting. I wonder if you could talk a little bit more. I mean, what do you envision? The history of nursing homes themselves probably impacts greatly about what's going to go on in the future, you know, with the different generations and what's going to happen with the Gen X generation, which is mine.
So, you know, a lot of this is going to come down to nursing home care. Long-term care is a funny combination of disability insurance and basically retirement insurance, and also health insurance, because it's all bundled together. All of this stuff happens together. Under our current Medicare scheme, most people actually go broke from the copays for their treatments. If you're hospitalized on sort of April 1st and then hospitalized on July 5th, you've got two $1,500 copays. And that begins to hit at savings on top of what your other retirement savings might have been in a pretty substantial way, particularly if you're also paying for home care and having people come in and help you out, et cetera. So all of those things are happening together. And most people in baby boomers, I don't know enough about Generation Xers, but baby boomers have not saved enough. And so that means that they will probably spend down even more quickly than their parents did, because the costs have gone up just in raw numbers, because the prices have gone up and their savings have not kept pace with that. So that's going to put them in some substantial crisis as they go forward. And how we socialize those costs when we can't even decide whether we're going to have a government running on Saturday or not is going to be a real challenge.
I see. Let's see. Do we have any other questions? Let's see. I think there's a Q&A. I see one. Thank you for this great presentation. Can you comment on the pandemic leading to any change in the very poor pay for people providing the very hard work of unskilled nursing home care and home care? Dog walkers likely make more money than the person caring for your mother or your grandmother. Like teachers, this questioner feels they are a group very underpaid.
So that's absolutely the case. And so right now, every nursing home in the country has got staffing challenges. I mean, virtually every one. And that comes from multiplicity of sources. First, of course, is the pay. Historically, it's been $15 or under. And right now, as nursing homes are struggling to fill their needed number of staff members, they can't even fill paying people $20 an hour. There's a shortage. Part of that is a shortage that is more broadly related to all kinds of low-income workers in America right now. But if you could get $20 an hour for doing something that doesn't, like dog walking, versus $20 an hour for something like doing that two-person lift I described, lots of people might want to be dog walkers. Now, I don't know what the volume of dog walkers is, but there's an awful lot of volume of nursing home staff and aides. There is money that's supposed to be put into one of those omnibus multi-trillion dollar packages, which is supposed to help pay for home care workers. I think there's also some language in about paying a living wage to skilled nurse facility workers, but all of that is probably going to go by the wayside because of the shenanigans going on in Washington now. So the issue of payment is huge, but that's a more general phenomenon. Is that, we're unwilling to pay people who take care of our children and who take care of our grandparents a living wage, and we haven't figured out yet what that living wage should be or how to decide what it can be, etc. So, and that's a general problem we have. The Brits are grappling with the same problem in nursing homes and care homes in England right now, and the wages are going up literally like the stock ticker is.
Thank you. I have another several more questions. Let's see. Great presentation, very insightful. My question is, do you believe vaccine hesitation among staff of nursing homes is similar to vaccine hesitation among staff of general hospitals or other healthcare providers?
So I think vaccine hesitancy in nursing home staff is exactly like vaccine hesitancy throughout the entire country. We did analyses, I think I probably glossed over, the most important determination of the vaccination rate in US nursing homes is the county in which you are residing, how red or how blue. That is, if you put it into a big regression equation, nothing is a function of what the who people voted for in the 2020 election.
Okay, thank you.
And that's really, it characterizes about, how people in America feel about things, but it's also characteristic of the political divide and the fact that people who work in those places are just like the people who don't work in those places, but who live in those same areas. It's not about whether you're working in a nursing home or a hospital or not. It might be the base rate of vaccination might be somewhat higher for those people because they care about their residents and their fellow workers, but the same attitudes prevail in the local community.
Okay, thank you. Do you have any comments or data on long COVID? Great talk and thanks from another attendee.
Well, I don't. We are doing another study now where we're taking data from Walgreens and CVS and all the Medicare beneficiaries who are their customers and matching it up with Medicare claims. And we're primarily answering who got vaccinated, what the adverse effects of vaccines were and what the effectiveness of the vaccines are. But as we're beginning to look at boosters, we're also beginning to look at long COVID. The problem is we don't have any really good claims-based definitions of long COVID. So we're stuck with the sort of case reports that come out of long COVID from idiosyncratic doctors' offices or small surveys or something like that. And there's not really population-based data on this topic.
Okay, we'll stay tuned.
I wish I did, but I hopefully will 6 months or 8 months from now.
Okay, another attendee says, thank you. I just learned so much from your cutting edge research. I wonder if you could comment further on what you said about Medicare Advantage programs being related to the decline in nursing home populations.
So Medicare Advantage programs have historically, until the last couple, 3 or 4 years, served a slightly less sick population, a slightly less old population, because partly because so many people entering Medicare are already part of managed care plans and just sort of convert into their same when they join Medicare, because they get lots of advertisement. But over the last few years, there are many more people who are older who are moving now to zero premium plans because they're poor and they can no longer afford the high cost of the sort of supplemental Medicare plans. And so, but until now, Medicare Advantage resident members use nursing home less because they're sicker less, and that means that they tend to go home more even if they live alone. Now, with a newer pool of people who are more likely to be dual eligible, more likely to be somewhat poor, those people are entering nursing homes. And so they look more like the standard fee for service. So what Medicare Advantage plans are doing, once you try to do the adjustment, is those who they're slightly less likely to enter a skilled nursing facility, Medicare Advantage patients leaving hospital, but even more importantly, when they enter a skilled nursing facility, they stay fewer days than a fee-for-service resident, even though they're otherwise identical in terms of, let's say, a hip fracture patient or a total knee replacement or something like that. And it's that sort of utilization review control that the Medicare Advantage plans is applying.
All right, thanks. And here we have, thank you for the wonderful presentation. Due to the heavy involvement of CMS and the cost considerations of the larger population entering in S&Fs, what are your thoughts to help support payment systems? Do you think an Affordable Care Act approach or hybrid public/private initiative might be feasible to help with systemic costs?
So Medicare pays reasonably well for post-acute care in a skilled nursing facility. Their payment scheme does a pretty good job of covering virtually all kinds of costs. The real problem for nursing homes is the fact that they're caring for patients who the bulk of their patient days in most nursing homes are reimbursed by Medicaid. So the problem is not post-acute care. The problem is long-term care, which is underpaid. So the margins are almost always negative. That is, there's no profit in it at all. And most nursing homes try to cross-subsidize post-skilled Medicare just because Medicaid is underpaid. So for example, in a state like Georgia, Georgia's not as bad as some states like Louisiana, but payment rates are well below the cost of doing business. And that's the cost of the labor, the cost of the mortgage, the cost of all of the equipment and all, you name it, et cetera. And that means as occupancy rate drops, you lose even more money. And so you can only make up so much money from having 5 skilled nursing facility patients. So given that mixture, as a society, we have to first answer the question, what do we want to cover as a society? Medicare is not long-term care. Right now, long-term care is either a poverty program or a private matter. And we haven't made a decision as to whether or not to combine those in some way to make it appropriate, to make it paid for. And that is a very important and difficult decision. Personally, it's hard for me to think about making that decision in favor of a socialization of long-term care if many, many people in Georgia and Texas don't have basic health insurance. But that's my opinion. There are other people who have other opinions.
Well, the questions keep on coming. Could better planning allow family members to continue to visit the nursing home residents during another pandemic? My friend literally stood outside her mom's window to see her.
There are so many tragic pictures of kids, grandkids looking at grandma inside. It's just the worst. It's just the worst. So there is, one thing most people in America don't understand is probabilities. It's terrible to say, but there is nothing that's foolproof. Never is it foolproof. We allow visits during influenza season, and we don't guarantee that people have to be vaccinated. Mm-hmm. On the other hand, influenza doesn't kill as efficiently or effectively as COVID does. It kills, but it not as efficiently or as effectively. And there are some kinds of treatment. As we know more about this particular virus, and as some of the treatments can become less burdensome or onerous, if you can do antigen treatment or antibody treatment, then it's not the worst thing in the world. It can be delivered in time. We'll be able to figure out a way to deliver that. It won't be as easy as Tamiflu, but it'll be somewhat easier. Then if everyone's vaccinated and everyone wears masks, and you could begin to think about different areas of a building that might be sort of sacrosanct for just visitation and then cleaned and just visitation, you could get away with something and have much more wholesale visitation going on. I don't think it'll be a while before we get back to everybody visits all the time, walk into the door with nothing. But part of that is respect from the community. The people in the community have also got to say, yes, I'm willing to become vaccinated in order to go see my mother, and not to pillory the nursing home and the state for imposing this kind of quote unquote sanction just because they don't believe it. And so there's this accommodation that has to happen all around. I'm hoping that we've learned something and there are models and best practices that we can develop so that we don't keep these poor people isolated from their family members.
Yes, that's so important. Here's another question. Thank you for the great talk. Do you see any changes happening with nursing home regulations post-COVID? It's a highly regulated environment, and it is of the other reason why physicians and nursing staff do not choose to work in this setting in addition to poor pay.
Yeah. So I just wish people could come up with a number like hospitals kill 100,000 people a year and have all these unintended errors and so on and so forth. There are lots of errors that happen in nursing homes, but I don't think nursing homes kill 100,000 people a year. But it's hard to know because they're sick and they have such a high death rate anyway. And so the question is that it's just so easy to hate nursing homes. And so it's so easy to pile on regulations in nursing homes and to audit them. It's also the case, it's kind of a self-fulfilling prophecy. When that horrible front page of the New York Times came up as a death pit, nurses, aides who work and like working in nursing homes begin to feel embarrassed. They don't want to tell people that they work in a nursing home because you work in a death pit. I mean, give me a break. That's just terrible. And so this self-fulfilling prophecy of the negative image translates to a poor self-image, to unwillingness to work in that setting, which means it's more difficult to recruit. And it's not just money. You can pay people 20 bucks an hour and they're not going to want to work in that environment. For the nurses, particularly the charge nurses and the physicians, the obligations and the onerousness of the regulatory documentation, it's actually much worse than it is in the hospital, because in the hospital, they get coders to do it for you. In the nursing home, they don't. And that's a challenge.
It sure is. You get another thank you for the great presentation. Do you have data on monoclonal infusion treatment among residents and LTCs?
We're assembling it right now. We've got data on about 1,000 nursing homes. We're pulling it together. Unfortunately, there are only X number of us. There are too many questions, and we're trying as hard as we can. But yes, we are pulling it together now.
Okay. Someone says, outstanding source of data, sir. I am founder of a digital health company, HumaCare Therapeutics, focused on infectious diseases affecting people of color living in diverse populations and the older adults. The most alarming trend is the misinformation affecting those who care for our most vulnerable populations, which is one of the leading causes of should I take the vaccine or not, and proper testing protocols in the nursing home environment. We have found such a large amount of ignorance among nursing home executives. Any comment on that?
So, it's not been my experience that the executives are ignorant. They may be ignorant about exact, infection control protocols, but because that's not their job. But they are not ignorant about the importance of vaccination, the importance of staffing, and so on and so forth. That's not been my experience.
And what will the impact of a PCR and influenza A/B testing strategy in nursing facilities be this winter? Or do you feel it's important to test for both?
So my understanding is that we are now there could be, it is available, more generally available influenza kit for rapid testing, as opposed to having to culture and take forever, which nobody does. And I think that's going to make a really big difference. PCR tests are still 50 bucks, and they still require 24 hours. Unless there's a new rapid test out that I'm not as familiar with, it takes at least a 24-hour period. Antigen tests, if you do them frequently enough, are a really good substitute if you're doing for population surveillance. There are also antigen tests for influenza, and there are people now working on combinations of those two, and you can get the derivatives of those two. In fact, I'm hoping that this will begin to occur more this winter as we go forward. My colleagues and we are working on it. My colleague Stefan Gravenstein is doing a trial right now of a new influenza, trying to control influenza outbreak with a Tamiflu-like substance. And so basically, as soon as there's a positive influenza case in a building, they will begin to administer Tamiflu prophylactically in the building as part of the testing protocol, as part of that process. And it's historically, about 20 to 30% of nursing homes have an outbreak during the course of the influenza season. So we're looking to see about controlling outbreaks and reducing those effects. We'll see how that happens, but key to that is being able to do these testings, and that's going to be part of this trial.
Okay, we have a couple more questions to go. Do you have data on residents that were vaccinated for shingles having a milder case of COVID or did not contract COVID at all?
We have the data. I have not asked the question. That's actually a great insight. I've not heard that. Maybe I'm missing something in the literature, but we know that having had a COVID, being positive for COVID in the past actually boosts the response of the vaccine. But I'm not sure about this. It's a great question. Easily asked.
Please comment on cost/fee difference between assisted living versus SNF in connection with levels of care. And also great presentation from Mac Willis Sr., who was one of our panelists last year.
So generally speaking, I mean, since assisted living facilities are by and large private pay, and or some people have some kind of insurance that helps contribute to the private pay, but it's essentially a private pay rate. The rates vary tremendously as a function of amenities, location, and who knows what, upscale and wine served at dinner and all kinds of things like that. Nursing home rates vary on the private pay side, of course, but since there are very few private pay residents in nursing home anymore, most of them who are long stay are going to be paid by Medicaid, and that's going to be a sort of a facility risk adjustment or case mix adjustment modified payment rate that ends up being, depending on what state you're in, $200 a day to $400 a day if you're in New York, or $450 a day in New York, but it's closer to $200 a day in the South, and that is more than, it's less than the highest private pay, $6,000, $7,000 a month for assisted living, but always lower than what subsidized assisted living payment rates are, to my knowledge.
Great, we're almost there. Is there potential for a different model of long-term care, such as the small home model, to expand post-COVID with consideration for infection prevention in addition to the social benefits?
So that's a great question. One of the implications of the environmental factor, that is high concentration of individuals and high concentration of staff, is smaller nursing homes in America, controlling for what week and county you're in, had by and large were less likely to have infections. And that's almost always because they have fewer staff. So it's all about the traffic. You got more staff coming into a building, you got more staff from more different places, all coming in, mixing together, and you have a greater opportunity for a spread event. And since every day is a potential spread event in a large nursing home, a small nursing home reduces that risk substantially. Mm-hmm. So small buildings will, of course, therefore have a lower risk of pandemic, and you therefore might not need as stringent infection control procedures in that place as you would in another place. I've had long conversations with people who are advocates of the small home, the greenhouse, and so on and so forth. And in fact, there's lots going for that particular model. But the problem is economies of scale, because, for economies of scale. And that means it's more difficult to pay for them unless you have 4 or 5 buildings on one campus, and then you can use one centralized resource for bringing other kinds of things in, or et cetera, or at least one management function, because you'd have separate kitchens and things like that. So those models, I think, are worth playing with, are worth working on. The real challenge is that the more buildings you have, so right now we have 15,000 plus nursing homes in America, and a legion of inspectors in every state in the country going out and inspecting them once or more a year. So imagine if there were, let's say 5 times as many buildings. Just think of what the regulatory and inspection oversight is. It is also the case that those of you in Georgia with long memories will remember that Georgia used to have adult daycare home, adult foster homes with 5 and 7 people living in places together, and they were converted trailers and all kinds of places in rural areas. And the Georgia Public Health Department, which had the inspection responsibilities, or the Department of Social Service, which had the inspection responsibilities, went crazy trying to inspect all those places. And there were periodic scandals worse than nursing home scandals, or at least commensurate with those nursing home scandals. So you kind of, pick your poison, and you decide how much risk will you tolerate in which direction, how much autonomy, and what's more important. And we have not, as a society, ever had that discussion about what's the risk tolerance for this, that, or the other. It's, all or nothing. You get on everyone thinks everything should be perfect. There should be no regulatory failures, no quality problems. And it's just, on the other hand, we're perfectly willing to tolerate X amount of rat hair in food and X amount of spoiled pork from the pigsties. So
And deaths from car accidents as well, right?
Exactly. So these are discussions that we're not comfortable having as a society.
We aren't indeed. I'm just going to follow that with a comment from one of the audience members. I kept my mom home and had to pay out of pocket for caregivers. The care in assisted living memory care was expensive and also poor. The care was poor. She was at home under my care during the beginning of COVID. The staff ratio was very low to patient load, and that's here in Georgia.
But not everybody can do that. And
right.
I think not everybody can. And one thing we'll learn as time goes on here is that family members their calculus has probably changed. People are less willing and ready to go to a nursing home and may be willing to tolerate that care because of the fear of being blamed for putting your mother in a nursing home even more now than they were 7 years ago.
That's right.
And the guilt is different in the quality, so that the only people who will be going to nursing home for long stay are those who have no other choice.
I think this is our last question, and then I'll follow it with a comment. Great data and presentation, thank you. Do you feel that the state servers should take a possible pause on issuing tag violations to nursing homes for staffing issues? They are all trying their best to recruit, hire, and maintain staff, yet some nursing homes are being issued tag violations for not having enough staff or the administration doing duties such as laundry.
Yeah, I am not going to comment on what state surveyors should or shouldn't do. The regulations are there. How they're going to work out in quality measures and all those other kinds of things is because the entire industry is in crisis now. I don't know. And, since many states are mandating vaccines and many companies are mandating, even though the state's not mandating vaccines for healthcare workers, and they're going to lose some staff who are good staff. And it's important to have the mandate, but it's sad that people are making that choice. And so that puts the nursing homes under great, great pressure. I would love to be able to cut facilities a break, to be able to say, let's put this on hold, let's do this, or, do something really wonderful and have a state, instead of just have Teach for America, have, be a nurse's aide for America.
That's a great idea. I love it. And finally, this is the final comment. Thank you for the great talk and answering all these great questions. Hail Brunonia.
Great. Thank you very much. Well, it was a pleasure. You did manage to give me the entire time. So good audience, very much
a half
engaged.
hour of questions. So Dr. Moore, we're so very grateful for your excellent presentation regarding nursing homes and COVID-19 impact. Thank you for being the keynote speaker for the 11th annual Bettye Rose Connell Memorial Lecture. For more information about how you can support this lecture, please scan a QR code that's going to be appearing on the screen. I believe if Miss Marisa Warner will, here it comes, there it is. So get ready, scan that code. The Bettye Rose Connell Memorial Lecture is dedicated to Dr. Connell's legacy to promote well-being among older adults, particularly those living in long-term care settings. Audience members, please remember to fill out the survey that we will be sending to your email addresses in just a few moments. Thank you all so much for attending, and thank you, Dr. Moore, for your great energy during this presentation and answering all those questions. We look forward to seeing all of you at many future lectures to come. Have a wonderful evening, everyone.
Good night. Bye-bye.
Take care. Thank you so much.